Hello everyone, let's study general bacteriology, laboratory diagnosis of bacterial infection, chapter 3.3. Preview, specimen collection, direct detection, staining techniques, other methods of direct detection, culture identification and AST, culture media, culture methods, culture identification, antimicrobial susceptibility test, serology, molecular methods, microbial typing. Introduction. Laboratory diagnosis of bacterial infection is useful for the following procedures. Identification, to identify the causative bacterial agent responsible for the disease. Treatment, to provide accurate antimicrobial therapy. Surveillance purpose, to assess the disease burden in the community by estimating the prevalence and incidence of the infection. For outbreak investigation, for example, diphtheria outbreak in the community, MRSA, methicillin resistance S. aureus outbreak in the hospital. To start PEP, post-exposure prophylaxis, useful in the infectious disease such as anthrax and plague. To initiate appropriate infection control measures, for example, contact precaution for MRSA infection, droplet precaution for diphtheria, and airborne precaution for tuberculosis. Laboratory diagnosis of bacterial infection comprises of several steps: specimen collection, direct detection, culture identification and antimicrobial susceptibility test, serology and molecular methods. Laboratory diagnosis, bacterial infection. First, specimen collection. Second, direct detection, microscopy, gram stain, acid-fast stain, Albert stain, histopathological staining, dark background, phase contrast and fluorescence microscopy. Antigen detection from clinical specimen. Molecular diagnosis, detecting bacterial DNA or RNA from clinical specimen. So laboratory diagnosis is used for specimen collection, direct detection via microscopy, antigen detection from clinical specimen, and molecular diagnosis, detecting bacterial DNA or RNA from clinical specimen. Culture, culture media, culture methods, colony morphology, smear and motility testing. Identification, biochemical identification. Automated identification methods, antimicrobial susceptibility testing, serology, molecular methods, typing methods. Specimen collection. Specimen collection depends upon the type of underlying infection. For example, in table 3.3.1, types of infection and various specimen collected: bloodstream infection, sepsis, endocarditis. Specimen collected are paired blood culture specimen collected aseptically by two-step disinfection of skin, first with alcohol followed by chlorhexidine. 8 to 10 ml of blood for adults collected in the blood culture bottles. Infectious diseases requiring serology. Blood 2 ml per investigation. Collection by minimal asepsis, one-step skin disinfection with alcohol. Collected with vacutainer. Diarrheal disease, stool, mucus flux, rectal swab. Meningitis, cerebrospinal fluid. Infection of other sterile body area. Sterile body fluid, for example, pleural fluid, synovial fluid, peritoneal fluid. Skin and soft tissue infection. Pus or exudate, wound swab, aspirates from the abscess and tissue bites. Anaerobic infection. Aspirates tissue in specimens, blood and sterile body fluid. Bone marrow, swab, sputum, non-satisfactory. Upper respiratory tract infection. throat swab with the membrane over the tonsil, nasopharyngeal swab or nasal swab. Lower respiratory tract infection, sputum, endotracheal aspirate, bronchoalveolar lavage, protected specimen brush, and lung biopsy. Pulmonary tuberculosis, sputum early morning and spot, collected in well ventilated area, gastric aspirate for infants. Urinary tract infection, midstream urine, suprapubic aspirated urine, catheterized patient, collected from the catheter tube after clamping distally and disinfecting, not from the urobag. Genital infection, urethral swab, cervical swab for urethritis, exudate from genital ulcers. Eye infection, conjunctival swab, corneal scarping, aqueous or vitreous fluid. Ear infection, swabs from outer ear, aspirate from the inner ear. The proper collection of specimen is of paramount importance for the collection of the bacteria in culture. General principles. The following general principles should be followed while collecting the specimen. Standard precautions should be followed for collecting and handling of all specimens. Before antibiotic administration, whenever possible, culture specimen should be collected prior to administration of antimicrobial agents. Otherwise, proper detection of the microbial agent would be difficult because of the killing of the microorganism and its excretion. Contamination with indigenous flora should be avoided, especially when collecting urine and blood culture specimen. So, for this reason only we use specific culture which grows only that specific organism. Swab, as through convenient but considered inferior to tissue, aspirate and body fluid. Container, specimens should be collected in sterile, tightly sealed, leak-proof, wide-mouth, screw-capped container. Labeling, all specimens must be appropriately labeled with name, age, gender, treating physician, diagnosis, antibiotic history, type of specimen, and desired investigation name. Rejection, specimen grossly contained or compromised but improperly labeled may be rejected. If anaerobic culture is requested, proper anaerobic collection container with media should be used. Specimens should not be sent in container containing formalin for microbial analysis. Specimen transport. Specimens should reach the laboratory for further processing as soon as possible after the collection. If required, appropriate transport media should be used. For most of the specimen, transport time should not exceed 2 hours. However, there are some exceptions. Specimens that require an immediate transport of less than 15 minutes, such as CSF and body fluids, ocular specimen, tissue specimens, suprapubic aspirate, and bone specimen. Urine midstream, added with preservatives. Boric acid is acceptable up to 24 hours, otherwise should be transported within 2 hours. Stool culture. Stool specimen should be transported within 1 hour, but with transport media, carry Blair medium, up to 24 hours is acceptable. Rectal swab, up to 24 hours is acceptable. For anaerobic culture, specimens should be put into Robertson cooked meat broth for any specialized anaerobic transport system and transported immediately to the laboratory. Specimen storage before processing. Many specimens can be stored at room temperature immediately after receipt. Up to 24 hours. However, there are some exceptions. Blood culture should be incubated at 37 degrees Celsius immediately up to receipt. Sterile body fluids, bone, vitreous fluid, suprapubic aspirate should be immediately plated upon receipt and incubated at 37 degrees Celsius. Corneal scraping should be immediately plated at bedside onto the blood agar and chocolate agar. Stool culture should be stored up to 72 hours at 4 degrees Celsius. Urine midstream and from the catheter. Lower respiratory tract infection, gastric biopsy for Helicobacter pylori can be stored up to 24 hours at 4 degrees Celsius. Direct detection. Direct detection of the bacteria in the clinical specimen plays a very important role in early institution of antimicrobial therapy. This method includes microscope demonstration of bacteria, staining techniques, and other methods such as detecting of antigen or nucleic acid in the clinical specimen. Staining. Structural details of bacteria cannot be seen under light microscope due to lack of contrast. Hence, it is necessary to use staining molecules to produce color contrast and thereby increase the visibility. Before staining, the smear are fixed so that they will not be displaced during the staining process. The fixation also protects the internal structure of the cell in a fixed position. It is done by two methods. First, heat fixation. It is done by gently flame heating on air-dried film used for bacterial smear, and second by methanol fixation used for blood smears. Common staining techniques used in diagnostic bacteriology includes simple stain. Basic dyes such as methylene blue or basic fuchsil are used as simple stain. They provide the color contrast but impart the same color to all the bacteria in a smear. Negative staining. A drop of bacterial suspension is mixed with dyes such as Indian ink and nigrosin. The background gets stained black, whereas the unstained bacterial or yeast capsule stand out in contrast. It is very useful in demonstration of bacterial or yeast capsules which do not take up the simple stains. Impregnation methods. Bacterial cell and structures that are too thin to be seen under the light microscope are thickened by impregnation of silver salts on their surface to make them visible, for demonstration of bacterial flagella and spirochetes. Differential stain. Here two stains are used which impart different colors to different bacteria or bacterial structures, which help in differentiating the bacteria. The most commonly employed differential stain are gram stain. It differentiates bacteria into gram positive and gram negative groups. Acid fast stain. It differentiates bacteria into acid fast and non-acid fast group. Albert stain. It differentiates bacteria having metachromatic granules from other bacteria that do not have them. Gram stain. The staining technique was originally developed by Hans Christian Stein in 1884. Even after more than 130 years of its discovery, and even in the presence of newer modern diagnostic facilities, still gram stain remains the most widely used test of diagnostic bacteriology. Procedure. Fixation. The smear made on a slide from bacterial culture or specimen is air dried and then heat fixed. Step 1. Primary stain crystal violet for 1 minute. Water rinse. Step 2. Mordant grams iodine for 1 minute. Water rinse. Step 3. Decolorizer acetone for 2-3 seconds or 95% ethyl alcohol for 20 to 30 seconds. Water rinse immediately. Counter stain. Dilute the carbol fuchsin or safranin for 30 seconds. Water rinse and blot. Principles and procedures for gram staining. Step 1. Primary stain. The smear is stained with the peranoselenine dyes, which such as crystal violet or gentian violet or methyl violet for 1 minute. Then the slide is rinsed with water. Crystal violet stains all the bacteria violet in color irrespective of whether they are gram positive or gram negative. Step 2. Mordant. Grams iodine, dilute solution of iodine is poured over the slide for 1 minute. Then the slide is rinsed with water. Grams iodine act as a mordant, binds to the dye to form bigger diiodine complex in the cytoplasm. Step 3. Decolorization. Next step is pouring of few drops of decolorizer to the smear, for example acetone for 1 to 2 seconds or ethyl alcohol for 20 to 30 seconds or acetone alcohol for 10 seconds. Slide is immediately rinsed with water. Decolorizer removes the primary stain from gram negative bacteria, while gram positive bacteria retain the primary stain. Note: decolorization is the most crucial step of gram staining. If the decolorizer is poured for more time, even the gram positive bacteria lose the color over decolorization, and if poured for less time, the gram negative bacteria do not lose the color of primary stain properly under decolorization. Step 4. Counter stain. Secondary stains such as safranin or dilute carbol fuchsin is added for 30 seconds. It imparts pink or red color to the gram negative bacteria. Alternatively, neutral red may also be used as counter stain, especially for gonococci. The slide is rinsed in tap water, dried, and then examined under oil immersion objective. Interpretation of gram stain. The smear is examined under oil immersion objective. Gram positive bacteria resists decolorization and retain the color of primary stain, that is violet. Gram negative bacteria are decolorized and therefore take counter stain and appears pink. The gram staining demonstrating the violet colored gram positive cocci is clustered and pink colored gram negative bacilli is in scattered arrangement. B. Acid fast staining shows long, slender, straight, or slightly curved beaded red acid fast bacilli. Source: A. Department of Microbiology, Pondicherry Institute of Medical Science. B. Department of Microbiology, JIPMEC. Principles of gram staining. Though exact mechanism is not understood, the following theories have been put forward. pH theory. Cytoplasm of gram-positive bacteria is more acidic and hence can retain the basic dye crystal violet for longer duration. Iodine serves as a mordant, that is, it combines with the primary stain to form a diiodine complex which gets retained inside the cell. Cell wall theory. Thus, this is believed to be the most important postulate to describe the mechanism of gram stain. Gram-positive cell wall has a thick peptidoglycan layer of 50 to 100 layers thick. with tight cross linkages. The peptidoglycan itself is not stained. Instead, it seems to act as an permeability barrier, preventing the loss of crystal violet. More so, alcohol is thought to shrink the pores of the thick peptidoglycan. Hence, the large diiodine complexes are not able to penetrate this tightened peptidoglycan layer in a gram-positive bacteria. Gram-negative cell wall is more permeable, thus allows the outflow of the crystal violet easily. This is attributed to thin peptidoglycan layer in gram-negative cell wall, which is not tightly cross-linked. Presence of lipopolysaccharide layer is in the cell wall of the gram-negative bacteria, which gets disrupted easily by the decarolizer, forming the larger pores that allows the diiodine complex to escape from the cytoplasm. Modifications of gram staining. There are few minor modifications of gram stain which vary slightly with the method described earlier. Kopilov and Biermann's modification. Primary stain and counter stain used are methyl violet and basic fuchsin respectively. Jensen method. This method involves the use of absolute alcohol as decolorizer and neutral red as counter stain, which is useful in meningococci and gonococci. Brown and Brenn modification. It is used for actinomycetes. Uses of gram stain. To differentiate bacteria into gram-positive and gram-negative, it is first step towards identification of bacteria. For identification, gram staining from bacterial culture give an idea to put the corresponding biochemical test for further identification of bacteria. To start empirical treatment, gram stain from the specimen gives a primarily clue about the bacteria present. Based on the shape and gram staining property of the bacteria, so that empirical treatment with broad spectrum antibiotics can be started early before the culture report is available. For fastidious organisms such as Haemophilus, which takes time to grow in culture, gram stain helps in early presumptive identification. Anaerobic organisms such as Clostridium do not grow in routine culture. Therefore, organisms detected in gram stain but aerobic culture negative gives a preliminary clue to perform an anaerobic culture of the specimen. Yeast. In addition to stain of bacteria, gram stain is useful for staining certain fungi like Candida and Cryptococcus, which appears gram positive. Quality of specimen. Gram stain helps in screening the quality of sputum specimen before processing it for culture. Presence of more pus and less epithelial cell indicates good quality of specimen. We will see acid fast stain in the next video.